नमस्ते, मैं डॉक्टर चारू हूँ और आज हम बात करने वाले हैं पॉलीसिस्टिक ओवेरियन सिंड्रोम के बारे में, उसका डायग्नोसिस एंड मैनेजमेंट। सिंड्रोम मतलब कलेक्शन ऑफ डिजीजेस। बात करते हैं पॉलीसिस्टिक ओवेरियन सिंड्रोम का। इट इज़ वन ऑफ द मोस्ट कॉमन एंडोक्राइन एंड मेटाबॉलिक डिसऑर्डर इन प्री मीनोपॉजल वुमेन। प्री मीनोपॉजल मतलब जिनका मेंस्ट्रुअल साइकिल चल रहा होता है। Heterogeneous by nature, PCOS is defined by a combination of signs and symptoms of androgen excess and ovarian dysfunction in the absence of other specific diagnosis. The etiology of this syndrome remains largely unknown, but mounting evidence suggests that PCOS might be a complex multigenic disorder with strong epigenetic and environmental influences, including diet and lifestyle factors. PCOS is frequently associated with abdominal adiposity, insulin resistance, obesity, metabolic disorder, and cardiovascular risk factor. The diagnosis and treatment of PCOS are not complicated, requiring only the judicious application of a few well standardized diagnostic methods and appropriate therapeutic approaches addressing hyperandrogenism, the consequences of ovarian dysfunction and the associated metabolic disorders. तो एंड्रोजन एक ऐसा हार्मोन है जो जनरली मेल में प्रोड्यूस होता है और फीमेल में भी ये थोड़ा अमाउंट में पाया जाता है। तो एंड्रोजन जो हार्मोन है उसका फंक्शन ऐसा है कि they are the group of hormones that contribute to growth and reproduction in both men and women, but it's basically male hormone present in female in small amount, play role in puberty, reproductive health and body development. So यहाँ पे एक पिक है जो डिपिक्ट कर रहा है, ये बेसिकली फॉरेन कंट्री का पिक है जहाँ ये विमेन अपना जो प्रॉब्लम है उसको एक्सप्रेस करना चाह रही है, जिसमें इसको PCOS डायग्नोज हुआ है बट ये बता नहीं पा रही है। तो ये चिट्स जो है वो रेफ्रिजरेटर में लगा के उनसे अपने रिलेटिव से कम्युनिकेट करने की कोशिश कर रही है। तो यहाँ पे ऐसा लिखा हुआ है कि इट्स बीन 2 months सिंस योर डायग्नोसिस एंड आई नो यू आर रिलक्टेंट टू टॉक अबाउट इट, बट वी हैव गॉट टू स्टार्ट डिस्कसिंग इट इन सम वे अदर दैन मैसेजेस left on the refrigerator with these tiny word magnets. मतलब we have to speak about it. अभी टाइम है कि इसके बारे में चर्चा की जाए। So essential of diagnosis है, इसमें क्लिनिकल और बायोकेमिकल एविडेंस ऑफ हाइपर एंड्रोजेनिज्म, जिसमें एंड्रोजन का लेवल बढ़ा हुआ हो, ओलिगो ओव्यूलेशन और एनोव्यूलेशन मतलब या तो कम ओव्यूलेशन या तो ओव्यूलेशन ना हो, पॉलीसिस्टिक ओवेरीज अल्ट्रासोनोग्राफी में डिटेक्ट किया गया हो। अब आते हैं ये जो डायग्राम है ये है पॉलीसिस्टिक ओवेरियन सिंड्रोम इश्यूज अमंग वुमेन अक्रॉस इंडिया ड्यूरिंग 2020 बाय एज ग्रुप। अब ये देखा जा रहा है इस ग्राफ से जो स्टैटिस्टा से लिया गया है 2020 का डेटा, जिसमें कि 16.8% जो यंग एडल्ट विमेन हैं 20 to 29 ईयर्स ओल्ड के हैं और इनको PCOS जो है ये ज़्यादा पाया गया, और बाकी फिर 30 से 44 ईयर ओल्ड तक में 11.58% जो है वो PCOS पाया गया। ये इलस्ट्रेशन यहाँ हमें दिखा रहा है कि PCOS वाली ओवरी कैसी होती है और नॉर्मल ओवरी कैसी होती है। तो ये जो डायग्राम है ये डायग्राम जो है ये दिखा रहा है कि इसमें नॉर्मल ओवरी जो है वो ऐसी दिखती है और जो मैच्योर फॉलिकल है वो इस तरह से रिलीज़ हो रहा है। उसके बाद पॉलीसिस्टिक ओवरी जो है वो बन रही है क्योंकि फॉलिकल प्रॉपरली रिलीज नहीं हो पा रहा। अब यहाँ पे जो सेकेंड डायग्राम है वो पैथोफिजियोलॉजी ऑफ पॉलीसिस्टिक ओवेरियन सिंड्रोम है। अब हम जानेंगे कि पॉलीसिस्टिक ओवेरियन सिंड्रोम और उसका डेफिनेशन क्या है और क्या क्या क्राइटेरिया है इसका। ये एक मोस्ट कॉमन एंडोक्राइन डिसऑर्डर है अमंग रिप्रोडक्टिव एज वुमेन. इट अफेक्ट्स approximately 4% to 12% of the population. Initially, it was termed as teen Leventhal syndrome based on a cohort of obese amenorrheic women with cystic ovaries. Because of the cystic changes found within the ovaries of affected patients, the term hyperandrogenic chronic anovulation syndrome, polycystic ovary syndrome, and polycystic ovary disease are now used to describe these patients. Individuals with PCOS do not have orderly follicular development. Most cycles fail to lead to the emergence of a dominant follicle or release of an oocyte leading to anovulation. The ovarian cortex becomes populated with numerous small follicles called as cysts, and the oocyte is not able to release properly. Hence, it causes cyst. The hyperandrogenic state is believed to be both a cause and effect of incomplete follicular development. Now coming to the diagnostic schemes for PCOS. Here, this diagram depicts the diagnostic schemes for PCOS. In 1990, National Institute of Health criteria required the presence of hyperandrogenism and irregular menses and allow for a clinical diagnosis without the use of imaging. Here it is ASRM Rotterdam classification. You can see it includes two of the three criteria. First is clinical or biochemical hyperandrogenism, HA, oligoanovulation, polycystic ovarian morphology. Polycystic ovarian morphology is identified by transvaginal sonography. Now NIH classification states it includes both clinical or biochemical hyperandrogenism, oligoanovulation. AEPCOS 2006 to include both clinical or biochemical hyperandrogenism, oligoanovulation, or polycystic ovarian morphology. Now the newest classification is NIH 2012. It identifies one of the four phenotypes using the Rotterdam criteria. That is HA, that is biochemical hyperandrogenism, plus OA, it is oligoanovulation, and PCOM is polycystic ovarian morphology. The most commonly used diagnostic criteria is 2003, as I told before. In 2009, the Androgen Axis and PCOS Society defined less exclusive criteria for PCOS, which required all of the following criteria be met: hyperandrogenism, hirsutism, or hyperandrogenemia. Hirsutism is the abnormal growth of hairs, ovarian dysfunction, oligoanovulation or polycystic ovaries, exclusion of the other androgen excess or related disorder in women. Of note, PCOS is always a diagnosis of exclusion in all definition. All other etiologies of hyperandrogenism must be ruled out. Patients with PCOS typically present with oligomenorrhea, amenorrhea, hirsutism, obesity, and infertility. All of some of these symptoms may be present. Virilization is not consistent with diagnosis of PCOS, and other etiology should be considered. Insulin resistance and metabolic syndrome are often associated with PCOS, and these patients should be screened for comorbidities. Providers should check a cholesterol panel, blood pressure, fasting glucose, 2-hour oral glucose tolerance test, and hemoglobin A1C. Now, consequences of PCOS. I have mentioned it in the chart. It is a short-term. It's a short-term consequence. You can see here. It's obesity, infertility, sleep apnea, irregular menses, depression, abnormal lipid levels, non-alcoholic fatty liver disease, hirsutism, acne, androgenic alopecia. Alopecia is बालों का उड़ना, insulin resistance, acanthosis nigricans, and long-term consequences are diabetes mellitus, endometrial cancer, and cardiovascular disease. Now, here it is given in brief that reproductive complications include: patients may have infertility due to oligoanovulation, defined as menstrual cycle which is greater than 35 days. Once they conceive, PCOS patients are not at higher risk of miscarriages but are at increased risk of gestational diabetes, macrosomia, and gestational hypertension. Gestational means during pregnancy. Endometrial hyperplasia and malignancy. Oligoanovulation leads to unopposed estrogen and lack of progesterone withdrawal. Over time, this can lead to proliferation of the endometrium that may result in abnormal bleeding and if untreated may progress to endometrial hyperplasia or endometrial carcinoma. Hyperinsulinemia and insulin resistance. Insulin resistance is often observed in patients with PCOS. Whether or not they are obese, insulin may cause or contribute to hyperandrogenic state by activating insulin receptor within the ovary, augmenting androgen secretion, or by acting on insulin like growth factor receptors. Patients with PCOS are at increased risk of impaired glucose tolerance and 5 to 7-fold more likely to develop diabetes type 2. Consequences of PCOS continued here. Now coming to metabolic syndrome. It is characterized by a cluster of conditions such as elevated BP, high serum glucose, increased waist circumferences, and abnormal cholesterol or triglyceride levels that, when occurring together, increase the risk of heart disease, stroke, and diabetes. The prevalence of metabolic syndrome in women with PCOS is twice that of control with similar age and body mass index, that is BMI. Additional PCOS patients are at higher risk of non-alcoholic fatty liver disease. Fatty liver disease is a disease of liver where accumulation of fats appear in liver, which can lead to abnormal liver function test, steatohepatitis, cirrhosis, and rarely hepatocellular carcinoma. Here are some statistics of PCOS, which is taken from an article. You can see here this obese patients data is higher and non-obese is less. So obesity leads to PCOS. Different causes of oligo or anovulation and hyperandrogenism. Causes of oligo or anovulation are PCOS. Here in this diagram you can see that evaluation and results, indicative results are there, where what hormone is increased and what criteria is less and what is increased in this. Like causes of oligo or anovulation, it can be PCOS, where total T level is increased, DHEAS level is increased, LH-FSH ratio is greater than 2:1, which is increased, AMH level is increased, and hyperthyroidism is TSH level, which is decreased, hypothyroidism is increased. Hyperthyroidism, where thyroid level is increased, TSH level is increased. Hyperprolactinemia, where PRL level is increased. Hypogonadotropic hypogonadism, FSH, LHE levels all are decreased. POI, FSH, LH levels increased, E2 levels are decreased. Causes of hypoandrogenism. In PCOS, late onset CAH 17 OHP level is greater than 200 Ng per dl. Androgen secreting ovarian tumor, total T level is greater than 200 Ng per dl. Androgen secreting adrenal tumor, DHEAS level is greater than 700 μg per dl. Exogenous androgen use, toxicology screen is increased. Summary of PCOS testing here is serum levels of FSH, LH, TSH, total T, free T, estradiol, PRL 17, OHP, DHEAS 2-hour glucose tolerance test, HbA1c lipid profile, measurement of BMI, waist circumference, and BP should be checked. Diagnosis. Coming to this point, this was our main focus, diagnosis and management. Diagnosis is thyroid stimulating hormone and prolactin, where thyroid disease may frequently lead to menstrual dysfunction. Thus, a serum thyroid stimulating hormone level is typically measured during evaluation. Hyperprolactinemia is a well-known cause of menstrual irregularities and occasionally amenorrhea. Elevated prolactin level lead to anovulation through inhibition of GnRH pulsatile secretion. testosterone and dihydroepiandrosterone sulfate. Tumors of the ovary or adrenal are a rare but serious cause of androgen excess. Various ovarian neoplasm, both benign and malignant, may produce testosterone and lead to viralization. Among others, these include the stromal tumors. Importantly, an abrupt onset or sudden worsening of viralization sign should prompt concern for a hormone-producing ovarian or adrenal tumor. Diagnostically, serum testosterone level can aid ovarian tumor exclusion. Free testosterone level are more sensitive than total testosterone level as an indicator of hyperandrogenism. Total testosterone level remains the best approach for identifying a possible tumor. Threshold value is less than 200 Ng per dl of total testosterone warrant evaluation of an ovarian lesion. Testosterone and dihydroepiandrosterone sulfate continued. Pelvic sonography is the preferred method to exclude an ovarian neoplasm in a female with very high androgen levels. Alternatively, computed tomography or MRI imaging also may be used. DHEAS is essentially produced exclusively by the adrenal gland. Therefore, serum DHEAS levels greater than 700 pg/Ld per L are highly suggestive of an adrenal neoplasm, and adrenal imaging with abdominal CT or MR imaging is warranted. Gonadotropins. During evaluation of amenorrhea, FSH, that is follicle stimulating hormone, luteinizing hormone, and estradiol level are typically measured to exclude premature ovarian insufficiency and hypogonadotrophic hypogonadism. Although classically LH levels measure at least twofold higher than FSH levels, this is not found in all women with PCOS. Specifically, 1/3 of women with PCOS have circulating LH levels in the normal range, a finding more common in obese patients. Moreover, serum LH level are affected by sample timing within a menstrual cycle, use of oral contraceptive pills, and BMI. Now, 17-alpha hydroxyprogesterone. The term congenital adrenal hyperplasia describes several autosomal recessive disorders that result from complete or partial deficiency of an enzyme involved in cortisol and aldosterone synthesis, usually 21-hydroxylase or less frequently 11-hydroxylase. As a result of these defects, precursors are shifted into pathways leading to androgen production. Thus, depending on the enzyme affected, CAH symptoms vary. It may present in the neonate with ambiguous genitalia and life-threatening hypotension. Alternatively, symptoms may be milder and delayed with adolescence or adulthood. In this late onset form of CAH, the enzyme deficiency leads to relative cortisol deficiency. In response, adrenocorticotropic hormone ACTH levels rise to normal cortisol production. Consequent to this accommodation, adrenal gland hyperplasia and elevated androgen levels develop. Therefore, symptoms of late onset CAH reflect accumulation of precursor C19 steroid hormones. These precursors are converted to dihydroxyprogesterone, androstenedione, and testosterone. The signs of hyperandrogenism predominate. With late onset CAH, the most commonly affected enzyme is 21-hydroxylase, and deficiency leads to accumulation of its substrate. 17-hydroxyprogesterone. Serum values are drawn in the morning from a fasting patient. Threshold value of 17-hydroxyprogesterone that measure greater than 200 Ng per dl should prompt on ACTH stimulation test. With this test, synthetic ACTH 250 microgram is injected intravenously. And 17-alpha hydroxyprogesterone continued, and a serum, the ACTH given during testing, stimulate uptake of cholesterol and synthesis of pregnenolone. If 21-hydroxylase activity is ineffective, steroid precursor up to and including progesterone, 17-hydroxypregnenolone, and especially 17-hydroxyprogesterone accumulate in the adrenal cortex and in circulating blood In affected individuals, serum levels of 17-hydroxyprogesterone can reach many times their normal concentration. Levels are greater than 100 Ng per dl from blood drawn after synthetic ACTH is given are indicative of late onset CAH. Coming to anti-Mullerian hormone, classic polycystic ovary contains 2 to 3 fold more growing pre-antral and antral follicles than normal ovaries. Within the granulosa cells of these developing follicles, the dimeric glycoprotein anti-Mullerian hormone AMH is produced. This will be anti-Mullerian hormone. Sorry for the spelling mistake. It is anti-Mullerian hormone AMH is produced. Serum AMH levels correlate closely with the number of pre-antral and antral follicles. Not surprisingly, AMH levels are 2 to 3 fold higher in women with PCOS compared with non-affected age-matched controls. For this reason, some view AMH as a potentially useful diagnostic marker for PCOS. That said, data regarding this marker in both PCOS and controls are incomplete and require further investigation before it can be adopted as a formal diagnostic criterion. Cortisol level. Cushing syndrome results from prolonged exposure to elevated level of either endogenous or exogenous glucocorticoid. Of these, the syndrome is more frequently caused by administration of exogenous glucocorticoid. Alternatively, the term Cushing disease is reserved for cases stemming from greater ACTH secretion by pituitary tumor. Cushing syndrome shares many symptoms with PCOS such as menstrual dysfunction, physical signs of androgen excess, truncal obesity, dyslipidemia, and glucose intolerance. Classically, moon phases and purple abdominal striae also are noted. Excluding exogenous causes, Cushing syndrome is a rare and routine screening in all women with oligomenorrhea is not indicated. However, in those with classic Cushing findings, proximal muscle weakness and easy bruising, screening is strongly considered. A 24-hour urine collection for urinary free cortisol excretion can be obtained. Alternatively, a dexamethasone suppression test administered 1 mg of dexamethasone orally at 11 pm and the plasma cortisol level is measured at 8 am. The following morning in women with a normal functioning feedback loop, administration of the corticosteroid dexamethasone lowers ACTH secretion and thus diminishes adrenal cortisol production. Normal testing values are, however, if a woman normal testing values are suppression, testing will remain elevated. Using a late night salivary cortisol level measurement, patient collects saliva samples between 11 pm and midnight on 2 separate evenings. Patient collects saliva samples between 11 pm and midnight on 2 separate evenings. Once identified, Cushing syndrome is treated based on underlying source of excess glucocorticosteroid. Coming to the next slide. Measurement of insulin resistance and dyslipidemia. Many women with PCOS have insulin resistance and compensatory hyperinsulinemia. The gold standard for evaluating insulin resistance has been the hyperinsulinemic euglycemic clamp. Unfortunately, this test and the IVGTT requires an intravenous line and frequently sampling are labor and time intensive and are not practical in a clinical setting. Accordingly, other less sensitive surrogate markers that evaluate insulin resistance are used, like a 2-hour GTT, a fasting serum insulin level, the homeostasis model assessment of insulin resistance, HOMA-IR, and quickie. It is quantitative insulin sensitivity check and calculation of serum glucose or insulin ratios. Several organizations recommend clinical DM screening and then periodic testing in obese or overweight women and adolescents diagnosed with PCOS. Guidelines endorsed by ESHRE and ASRN promote baseline DM screening for all women with PCOS and subsequent testing to 1 to 3 year intervals based on risk, serum fasting glucose level, hemoglobin A1C, HbA1c level or 2-hour OGTT is suitable. Of these, 2-hour OGTT is favored or high risk characteristic, which are obesity, BMI which is greater than 25 kg per meter square or greater than 23 in Asian women, a personal history of IGT or hypertension, Asian ethnicity and family history of type 2 diabetes mellitus. Women with PCOS can demonstrate a worsening of glucose tolerance over time with a reported conversion rate of approximately 2% per year to type 2 DM. This affirms the importance of periodic assessment of glucose tolerance with a 2-hour OGTT in women with PCOS. In addition to assessment of insulin resistance in overweight and obese women with PCOS, a fasting lipid profile is recommended to evaluate dyslipidemia. Subsequent testing is based on global CVD risk. Others support initial lipid screening for all women with PCOS. Now sonography. Histologically, a polycystic ovary displays a greater number of ripening and atretic follicles, cortical stromal thickness and number of hilar cell nest. Many of these tissue changes can be sonographically, and pelvic sonography is commonly used to evaluate the ovaries in women with suspected PCOS. Moreover, sonography is particularly important for women with PCOS seeking fertility and in women with signs of virilization to exclude an androgen producing ovarian cancer. Sonography continued here. Polycystic ovarian morphology is one criterion for PCOS as we had discussed before. Earlier sonography criteria for PCOM include 12 small cysts equivalent to 12 small cysts, that is 2 to 9 mm in diameter, or an increased ovarian volume greater than 10 ml or both per ovary. More recently, follicle number per ovary threshold values have been raised to improved sonographic imaging resolution, namely an FNPO threshold of greater than follicles and or ovarian volume greater than 10 ml. In either ovary has been adopted by ESHRE and ASRM. The AEPCOS guidelines use the same ovarian volume value but a higher FNPO threshold of equivalent to 25 follicles. Notably, criteria do not apply to women taking combination oral contraceptive pills. Remarkably, studies using sonography have shown that at least 23% of young women have ovaries that exhibit PCOM. Yet many of these women have no other PCOS symptoms. In addition, a polycystic appearance of the ovaries can often be found in other conditions of androgen excess such as AACAH, Cushing syndrome and exogenous use of androgenic medication for this reason. PCOM found during sonographic examination is not used solely for PCOS diagnosis. Importantly, PCOM often reflects normal adolescent ovarian physiology. The sonography for PCOS evaluation is not recommended within 8 years of menarche. Now coming to the treatment part, which is very important part. Treatment depends on underlying etiology and the desire for pregnancy. Lifestyle modification should be first line in the management of hyperandrogenism. For those individuals who suffer from hirsutism and obesity, weight loss of even 5% can often improve symptoms related to PCOS. Weight loss may result in elevation of SHBG, a decrease in bioavailable testosterone, and an improvement in insulin sensitivity. Oral contraceptive pills reduce circulating gonadotropin level and increase SHBG level. Both work to decrease circulating androgens. OCPs are the first line of treatment of oligomenorrhea, hirsutism and acne caused by PCOS. Progestins decrease total androgen levels by reducing the activity of 5 reductase. Specific progestin with lower androgenicity include desogestrel, cyproterone acetate and drosipyrinone. Overall OCP usage result in an overall decrease in formation of new androgen dependent hair growth and androgen stimulated acne. All low dose OCP preparation are believed to have similar result. Now, if combination of oral contraceptive pills are contraindicated or not desired, medroxyprogesterone acetate may be administered. That is 5 to 10 mg for 10 to 12 days every month or every other month to produce regular withdrawal bleeding. Patients should be cautioned that unless contraception is used, pregnancy is possible with cyclic progestin therapy. Metformin hydrochloride is a biguanide anti-hyperglycemic drug. US Food and Drug Administration, that is FDA, approved for the management of type 2 diabetes mellitus. Metformin decreases hepatic gluconeogenesis, decreases the intestinal absorption of glucose, and improves insulin sensitivity in the peripheral system, including skeletal muscle, liver, and adipose tissue. In some studies, metformin has been shown to restore menses in approximately 50% of women with PCOS and can improve plasma insulin and insulin sensitivity, reduce serum free testosterone, and increase serum HDL cholesterol. Dosing. The optimum dose of metformin for restoration of menses in women with PCOS ranges from 500 mg by mouth 3 times daily to 850 mg by mouth twice daily. Patients should be titrated up to appropriate dose of this medication, starting at the lowest dose once daily due to the gastrointestinal side effects. Metformin has a limited role in treatment of hirsutism. Other agents may be added to metformin to improve these symptoms. Metformin appears to be unique among insulin sensitizing agents in that it can improve weight loss, hyperandrogenism, and menstrual cycle in individuals with PCOS. Treatment of hirsutism. Hirsutism is slow to respond to hormonal suppression. Result may not be seen for up to 6 months. Androgen suppression will not alter previous hair growth patterns. Spironolactone therapy is often initiated if OCP use is not an option for the treatment of hirsutism, or if results from OCP therapy are not optimal. Spironolactone, an aldosterone antagonist, is an hypertensive agent, directly inhibits 5 reductase and decreases androgen synthesis. Because of potential adverse effect on genitalia on male fetuses, spironolactone should be used with contraception in sexually active women. Other side effects include diuresis, orthostatic hypotension, fatigue, dysfunctional uterine bleeding, hyperkalemia, that is increase in potassium level, and breast enlargement. Flutamide is a non-steroidal anti-androgen often used for prostate cancer that blocks the binding of androgen to its receptor, which can cause inhibition of new hair growth. Side effects include dried skin and rarely hepatotoxicity. Liver function should be monitored during treatment. Due to adverse fetal effects, effective contraceptive therapy is mandatory. Finasteride, an inhibitor of mostly type 2-5 reductase, finasteride was developed initially as a treatment for prostate hypertrophy and cancer. By inhibiting 5 reductase, the drug decreases DHT activity at the level of the hair follicle. Finasteride treatment prevents new hair growth and decreases the terminal hair shaft diameter. No major side effects have been associated with this drug, again due to adverse fetal effect. Reliable contraception should be used. Minoxidil is the only drug approved by the FDA for the treatment of androgenic alopecia in women. It promotes hair growth by increasing the duration of anagen phase and enlarging miniaturized and suboptimal follicle. It is available over the counter as a 2% and 5% topical solution. Now, eflornithine hydrochloride, Vanica trade name, 13.9% cream reduces unwanted facial hair. Eflornithine is a potent antagonist of ornithine decarboxylase, the enzyme necessary for the production of polyamines, organic compound that stimulate and regulate the growth of hair follicles and the other organs. Twice daily topical use has shown improvement after 24 weeks in some clinical trials. The benefit is usually first seen at 8 weeks. Hair removal by mechanical methods such as shaving, waxing, depilatories, lasers, and electrolysis are often used by patients. However, hair regrowth is common. Other adverse effects including inflammation, blistering, hypopigmentation, and scarring that are mostly commonly seen in dark-skinned women. Surgery. Laparoscopic ovarian drilling and wedge resection is used to be standard treatment prior to ovulation. Inducing agents. However, because of the high incidence of pelvic adhesions and risk of decreased ovarian reserve, this approach is rarely used today and is now considered second line therapy. Fertility treatment for polycystic ovarian syndrome. Ovulation induction medication are frequently required. Clomiphene citrate. Clomid is a selective estrogen receptor modulator that functions as an estrogen receptor antagonist in the hypothalamus, thus stimulating gonadotropin releasing hormone and subsequent follicle stimulating hormone secretion. Typical administration is oral doses of 50 to 150 mg per day for 5 days on a monthly basis to induce ovulation in infertile women. It is not used for cycle regulation or as a primary treatment for hirsutism. Letrozole is an aromatase inhibitor. It prevents the conversion of androgen to estrogen in the peripheral bloodstream. The reduced estrogen level leads to a subsequent negative feedback to the hypothalamus, which then triggers a compensatory increase in hypothalamic gonadotropin releasing hormone secretion, followed by an increased release of pituitary gonadotropin, FSH and LH. Some consider letrozole to be first line for ovulation induction for patients with PCOS when compared to clomiphene. Letrozole resulted in higher pregnancy and live birth rates with no difference in miscarriage or multiple birth rate. However, caution is advised because letrozole is not FDA approved for ovulation induction and is contraindicated for using during pregnancy. Gonadotropin such as recombinant FSH and human menopausal gonadotropin directly stimulate the ovary and may be used to induce ovulation in letrozole and clomid resistant PCOS patient or if undergoing in vitro fertilization. Metformin. See treatment or hyperandrogenism PCOS. Metformin was discussed before. Is not an effective as monotherapy ovulation inducing agent. Letrozole and clomid but can be used in combination. In vitro fertilization is the next step if weight loss or ovulation induction with medications are unsuccessful. Now we come here to the end of the slide. Discussing further, I have to say that there are some more recent advances added to the PCOS treatment. It is the myo-ND chiroinositol that are insulin sensitizing agent that act as second messenger in insulin signaling and Orlisat. It is used for obesity and weight loss. But remember, these medications should only be taken under the prescription of gynecologists. Thank you.